Good evening, everyone. And I would like to thank the organizing committee, especially Dr. Shah and Dr. Patil, for the invitation to present today. This is a fantastic two-day course, and I will start my presentation. But first, I would like to again thank Dr. Patil, because many of the slides I'm going to use today are from hers, and I want to make sure that I give her all the recognition that she duly deserves. So my job today is to talk about ovarian stimulation for PCOS in IVF. And as you all know, that most individualized ovarian stimulation protocols are based on these parameters of ovarian reserve testing. We know we have age already. We need to know what the FSH is, and more importantly, the AMH and the antral follicle count. So in the US, we rely mostly on AFC. We still rely on AMH. In other parts of the world, people rely more on AMH versus AFC. But I do my own ultrasounds, and for me, antral follicle count is really quite important. And again, this slide from the PCOS Society of India, which hopefully I'll be in person in 2022 to present to you. Another thing we're adding, obviously, is BMI. This may not be a big problem in India, but in the US, it really is a huge problem. And we have to include BMI as a parameter when we decide on stimulation protocol. So the challenges for ovarian stimulation in PCOS has to deal specifically with two main things: efficacy and safety. And safety is really the biggest thing that we worry about in women with PCOS, because they're by definition hyper responders, and therefore we worry about the risk of ovarian hyperstimulation. Obviously, another big worry is multiple pregnancies when you transfer more than one, which in the US, luckily, most of us are only transferring a single embryo at this point. So we want a safe, efficacious protocol that results in a pregnancy and with as minimal complications during pregnancy as possible. So what are the risk factors when we're dealing with high responders, especially women with PCOS? Obviously, an AMH is a big marker. So when the AMH is above 5 nanogram per milliliter, we have more than a 3-fold increase in ovarian hyperstimulation. High antral follicle count. Obviously, when you do your ultrasound and you see like 30 plus follicles in each ovary, you know that you're dealing with a hyper-responder who is at a very high risk at developing hyperstimulation. And when AFC goes above 30, then you're dealing with a substantially higher number of risk of ovarian hyperstimulation. Rapidly increasing estradiol during stimulation. If the estradiol goes above 3,500, especially above 5,000, you're really dealing with a very high risk factor at developing hyperstimulation. When you do your ultrasound on the day of trigger and you see more than 19 large and medium-sized follicles, that's another marker. If you do your retrieval and you have more than 20 eggs, that's by definition a hyperresponder. Occurrence of a pregnancy will substantially increase the risk at developing early OHSS. And in some studies, blood group A is associated with a higher incidence of OHSS. So what are the grade A evidence to try to minimize the risk for PCOS patients? And again, this is one of the slides of Dr. Patil that I borrowed. The grade A evidence is include mild ovarian stimulation, the use of GnRH antagonist protocols, and using GnRH agonist trigger. These are all grade A evidence. Grade B evidence, recombinant LH for trigger. In the US, we don't have LH to trigger, but it's grade B at best. And obviously, grade C, I would not rely on using a lower dose of HCG or recombinant HCG, because all you do, you're still exposing a patient like this to the risk at developing significant hyperstimulation, ovarian hyperstimulation, when you give them any HCG. So again, the grade A evidence to summarize are mild ovarian stimulation, GnRH antagonist protocols, and GnRH agonist trigger. And so increasing efficacy also is important, but when we have multiple follicles, we worry about the increase in progesterone. And when we see these cases, we have to do a freeze-all and then transfer in subsequent FET cycles. Reducing complications, as I told you, we need to try to decrease the incidence of OHSS, multiple pregnancy rates, and again, decreasing imprinting disorders and epigenetic abnormalities, but those will be touched on by other speakers. So what's the difference when we use GnRH agonists in terms of an LH surge compared to natural surge? So when we use a GnRH agonist, it has a shorter ascending phase and a longer descending phase. And the ascending phase is over 4 hours. And so that GnRH agonist, at least stimulation lasts for about 20 to 24 hours compared to 36 to 48 hours for an LH surge during a natural cycle. And when you use GnRH agonist, you also are releasing FSH, which helps with inducing LH receptors in granulosa cells, promoting oocyte nuclear maturation, cumulus expansion, sorry, and suppression of intercellular coupling of cumulus cells. And as I mentioned briefly, when you use GnRH antagonists, you decrease OHSS incidence by 60% compared to agonist protocols. And you also reduce cycle cancellation rate because of the fear of OHSS by 53%. So whenever you use an antagonist protocol, and make sure you're already reducing risk of cycle cancellation and also reducing the incidence of OHSS. And in my opinion, all PCOS patients should go with an antagonist protocol. So antagonist protocol coupled with GnRH agonist trigger is really efficient, safe, and simple, and it is the best method of presenting OHSS, which can be deadly in some patients. What about serum progesterone? Everybody remembers Bosch's 2010 paper. This is a paper from China from 2012 in fertility and sterility, again, looking at poor responders, normal responders, and high responders. And in high responders, if you're planning on using a fresh transfer and you're not worried about OHSS, but you always are, but if you're not worried, you don't see a drop in pregnancy rate until the progesterone really goes above 2.25. I personally had pregnancies and deliveries at progesterone of 2. So that by itself should not push you to cancel the cycle. But as you see, there's differences between poor responders and normal responders. With normal responders in that study, the pregnancy rate did not drop until a progesterone level of 1.75 nanogram per milliliter is reached. And this is why you really have to rely on your own lab. Bosch's paper, which looked at 1.5 nanogram per milliliter, that works great in EV in Valencia in Spain. It doesn't work for other programs. So each program has to look at its own cutoff of what progesterone is in both poor responders, high responders, and normal responders. But when you have elevated progesterone, that effect is solely on the endometrium, and it does not decrease the chance of a frozen embryo transfer in a subsequent cycle. So again, this paper from Human Reproduction in 2020 looked at this. Progesterone elevation during IVF stimulation does not predict embryonic competence, as late follicular progesterone progesterone rise is neither associated with impaired embryonic development nor increased rates of aneuploidy. And patients can expect to optimize implantation by employing an FET strategy. And in patients presenting with late follicular phase progesterone elevation, a freeze-all strategy with transfer in subsequent cycle with or without PGTA is what is recommended. So what are the options for us? For patients with PCOS, when they come to see us, what do we tell them? They can undergo a fresh transfer, they can undergo a fresh transfer, and if they don't get pregnant, you have frozen cycles, or do what's called a segmental thing, whereby you do a freeze-all and then you do multiple transfers until a pregnancy is achieved. And this could be planned or unplanned. So this is, everybody remembers this paper from China that was published in the New England in 2016, which looked at randomizing women with PCOS to a fresh transfer versus a freeze-all and then do an FET. Live birth rate was significantly higher with a freeze-all strategy. Pregnancy loss rate was significantly lower with an FET. And OHSS, as you would expect, is substantially higher when you do a fresh embryo transfer. However, in FET cycles, they're not without their risks. And one of the risks is preeclampsia. And in this case, they had 5 neonatal deaths that were in the frozen group and none that were in the fresh group. So again, you have to look at the pros and cons when you decide to do this. This is a paper that was published from Sohail Muasher's group at Duke from 2018, looking at nearly 83,000 cycles, looking at poor responders, normal responders, and high responders, and with thousands of patients in each arm from the SART database. And in a schematic format, you can see that a frozen embryo transfer strategy is higher in hyper responders, but not in normal responders or in poor responders. So this is clear evidence that in hyper responders, it's best to freeze and then do a frozen embryo transfer. So a freeze-all strategy employs gonadotropins and an antagonist protocol, agonist trigger, vitrification, and then do an FET. But as I mentioned briefly, disadvantages not only include preeclampsia, but they also include large for gestational age babies and a higher risk of placenta accreta. The cost effectiveness of a freeze-all policy is still being debated, but this is a paper from Rock from Brazil looking at 2015 that showed a freeze-all strategy is cost effective when you're dealing compared to a fresh embryo transfer, especially when you're dealing with women with PCOS. What about imprinting disorders? I'm just going to mention the slide very quickly because somebody else is going to discuss this. Whenever we're hyperstimulating and transferring an embryo in a programmed cycle or in a fresh cycle, we may be increasing the risk of imprinting disorders. But this is definitely a topic that needs to be addressed moving forward. So vitrification has significantly increased in usage since 2009 when it became the mode of freezing compared to slow freeze. This is a slide from the SART database looking at the cycles that involved cryopreservations in the US by 2016 compared to 2007. And you can see this is an exponential rise in the use of frozen embryo transfers. And in 2016, the pregnancy rate from the SART database was higher with a frozen embryo transfer cycle than was with a fresh transfer. And this is from the 2018 CDC report that came out a few months back. I'm just going to show you one thing, that the percentage of transfers using frozen embryos is already over 70% as early as 2018. 2021 in the US, I will tell you it's over 90%, and there are many programs that stop doing fresh transfers. I still do maybe about 5% or less of my patients are fresh cycles, but you have to realize that in the US, the mean age of women is substantially higher. In my practice, the mean age is about 40 at this point. So many of those women end up undergoing PGTA testing, and that, along with safety, has really caused an exponential increase in freeze-all cycles. What about choice of gonadotropin? So I'm not here to talk about any pharma company versus another. This is a study that was recently published looking at different stimulation protocols and whether they make a difference specifically in PCOS patients. So for those of you that read the Megaset HR paper that was published in February of 2020, this was a randomized accessor blind clinical trial looking at non-inferiority between HP-HMG versus REC-FSH, specifically in high responders, and they're defined by an AMH above 5 nanogram per milliliter. It was an antagonist protocol with HCG trigger, except if you had more than 30 follicles, more than 12 millimeters, or the peak estradiol was above 5,000. At that point, you can use an GnRH agonist trigger and freeze all. The great thing about this study is all the embryos were biopsied for PGTA, and then they had if you're doing a fresh transfer, the best quality fresh embryo was transferred, obviously after being biopsied, not knowing what the results were. And if you did a freeze all, you biopsy all the embryos and you freeze them, and then you do an FET cycle afterwards. 31 centers in the US, 620 patients were randomized. So the protocol was starting with 150 IUs, which is what anybody should do when you're dealing with hyper-responders and PCOS patients. After 5 days, you adjust by a maximum of 75 IU. A GnRH antagonist was introduced when the follicles reach about 14 millimeters and or serum estradiol were above 300 picogram per milliliter. Triggered with a recombinant HCG when at least 3 follicles were more than 17 millimeters in diameter. But as I mentioned briefly, GnRH agonist trigger was used if more than 30 follicles of more than 12 millimeter are noted and or the peak estradiol level was above 5,000. The embryos were grown to blastocyst. All the embryos were biopsied. If you're doing a fresh cycle, a single blastocyst was transferred. The others were frozen, and vaginal progesterone was used 100 BID as a luteal support. 10 to 14 days later, you do a pregnancy test, the first ultrasound between 6 and 7 weeks, and ongoing pregnancy when women went above 10 to 11 weeks of gestation. As I mentioned, 620 were randomized, 310 in each arm. How many of the patients received a GnRH agonist and freeze all? In the HP-HMG arm, 11.9% compared to 17.5% in the REC-FSH arm. What about cycle outcomes? Ongoing pregnancy rate was higher in the HP-HMG compared to REC-FSH. Ongoing pregnancy rate was higher by 5%. Live birth rate was higher by 3.5%. And early pregnancy loss was higher by 10% in the REC-FSH arm. But more importantly, this is the live birth rate, no real difference, 3.6 increase in percent increase between REC-FSH and HP-HMG. But the surprising thing about in this study was the frozen embryo transfer cycle was 63.4% in the HP-HMG arm compared to 50.8% in REC-FSH arm. Remember that all these transfers were with euploid embryos, so all were PGTA tested. But more importantly about OHSS, what are the risks of OHSS? So if you look at a modified intent to treat, it is higher with, it's about 2 times higher with REC-FSH, and most of these, as you would expect, are early OHSS cases. And if you go by the number of oocytes, as you would expect, the more oocytes you get, the higher the chance at developing OHSS when you undergo a fresh embryo transfer. And if you have retrieved more than 25 eggs, the chance at having OHSS is 32.4% in REC-FSH compared to 8.3% in HP-HMG. So who do we do freeze all cycles on? Elevate progesterone and negative outcomes. Obviously, whenever you see elevated progesterone, as defined per your lab, as I said, most people look at about 1.5 nanogram per milliliter, but you really have to look at your own lab. Then I will tell you do a freeze all. Aggressive stimulations will result in more follicles that will grow and therefore a higher progesterone, especially when you're using REC-FSH only protocols. The window of implantation is altered with ovarian stimulation, and it's even more altered with GnRH antagonist cycles. This was published back in the early 2000s, throughout the 2000s by Kolybianakis from Belgium first and then in Greece. And obviously the window of implantation will also be affected by rising progesterone, or if you have a slow growing embryo. So if you do not have an expanded blastocyst by the day of transfer by day 5, then you should not be doing a fresh transfer. Obviously, PCOS cases are the ones who should be getting a freeze all strategy. So this is again a slide from Dr. Patil, but looking at the phenotype of PCOS also is a strong predictor, especially those with hyperandrogenic phenotypes. And these you should do lifestyle modification, diet modifications, metformin, all these things. But I know there's at least a talk or two on adjuvants. So I'm going to move quickly with this. So based on randomized trials and other factors, minimizing the risk of cancellation of cycles, OHSS, poor response on multiple pregnancies, we need to be efficacious and safe. By doing this, we can help to increase the success of ERT and decrease stress and anxiety and decrease complications. So this, so Dr. DeVroy's paper from OHSS-free clinics from as early as 2001 is seeming to come to life right now by using GnRH antagonist protocols and using GnRH triggers. We are nearly eliminating OHSS cases, and by transferring a single embryo, we are nearly eliminating multiple pregnancies. We can't do anything about monozygotic twins, but by at least transferring a single embryo, we are decreasing the incidence of multiples as much as possible. We're all after better neonatal outcomes. So in conclusions, individualized simulation. Every woman is different. We should always use a different protocol for every single patient. In PCOS patients, start with the lowest needed dose, and that's usually 150 IUs. Fresh versus frozen. Recent data point to a safer strategy using freeze-all. If planning a fresh transfer, patients should be counseled that their cycle may well get converted to a freeze-all if progesterone is elevated and there is a risk of OHSS. In my opinion, any patient who has an OHSS should be told from the beginning that they should be having a freeze-all cycle and not have to worry about the risks involved, especially OHSS. As I showed you earlier, the choice of gonadotropin, if a fresh cycle is planned, seems to be important. Antagonist protocols with GnRH agonist triggers, but be careful when adding any HCG to the GnRH agonist. I've had a case when I added some HCG to a GnRH trigger. That's a patient that had an AMH of 50.4 and she's still hyperstimulated. I tapped her within 48 hours without any issues. But to do a freeze-all strategy, your lab has to be excellent at doing vitrification, and you need to have an excellent frozen embryo transfer success rates. Otherwise, you're defeating the whole purpose. So then you do an FET cycle using elective single embryo transfer to minimize multiples. And as I mentioned briefly, freeze-all cost analysis need to be addressed, but I'm afraid that this is not going to be looked at anymore since most people are utilizing a freeze-all strategy for PCOS patients at this point. And with this, I'm going to end my presentation and open the floor for any questions. Thank you very much.